And then I'm going to just hand the mic over to my colleague, Dr. Rendis, to give us a little bit of instruction for our break. Thank you all so much for your time today.
And thank you for that wonderful panel. I just wanted to say that our panel members from panel 1 are very graciously offering during the next hour break to be available for some dialogue with anyone who would like to be on for about 15 minutes. So we welcome anyone to join us who did not have an opportunity to ask their questions and or make some remarks. And on that note, I want to say thank you very much for all of you who need the break or have another appointment. Please join us back promptly at 2 o'clock for a very stimulating afternoon. And thanks again to everyone. So Monica, Hoya.
Yep, I'm here.
We're
Okay,
here.
great. Okay, good.
Y'all aren't quiet. Any questions from the audience?
We'll see. We'll see who stays on.
Okay. Monica and I could just ramble. We're good at that too.
Or we can, make some comments specific to, questions that have come through on Twitter.
Yeah. Ooh.
And Marina has about 15 minutes. So we just want to be all respectful of each other.
Well, since we are recording, I do want to get to something that was said on the last panel in terms of timing of maternal deaths. A lot of work in nursing, especially on labor and delivery staffing units, have been done by Kathleen Simpson and Audrey Linden, our previous UCSF colleague who is now at NYU. They published a couple of different papers that were very specific to understanding not just timing of maternal death and missed nursing care, but also really thinking about this issue of change of shift in hospital structure and staffing. So there are papers around that. And then it would be remiss not to point out that a smaller data visualization paper that Neil Shaw did a couple of years ago, and the only reason I know this is because it looks exactly like a sundial. It looks at the timing where he was trying to predict timing of potential harm for maternal health and maternal death, and what are the crucial points. And change of shift was actually one of them, right? Because we all have to communicate as a healthcare team in terms of passing the mic and carrying care forward, but that leaves a sort of skeleton crew of people who are keeping their eye on, sort of the unit as a whole. And so really bringing forward this notion, how can we think differently about change of shift and about space and about how we sign off patients so that there could be different types of overlap to make sure that I stayed on patients in those crucial windows. So there has been some time looking at the timing, what are the crucial, both spatial and temporal points in pregnancy-related care in hospitals and healthcare institutions. But again, my original point was that that's episodic. That's one place of space and time that we should be thinking about.
Monica, you bring up a really excellent point, and I'm glad that you raised it again to address the question. I think the other issue too is that from at least sort of thinking about a quality improvement standpoint, we've sort of pulled ourselves away from time as an opportunity for an objective measurement of response to care. In the area of neonatal medicine, we're getting, I think, better at that in terms of thinking out, for example, the golden hour of care in terms of neonatal resuscitation and support. And in maternal health, I think we're just beginning. I mean, the fact that we've been talking about these time periods that may be critical and different in terms of risks for death are really important. But remember that we're no longer measuring decision to incision as one of those interventions for time for cesarean section. So, how can we use time as an objective measure in terms of effective responses to care is going to be really important. But also, where are situations where the time window may not be measured, for example, in a hospital, but we still need to think about that as well.
So I just want to offer, because I don't have a lot of time, and when you watch the TV show that we just had the honor to be a part of creating with New Amsterdam, you can see how patients experience this conversation we're having right now about time. So we operate inside of hospitals and birthing on a schedule, on a time clock. So this entire conversation was a little triggering for me because we are trying to get away from, at least I would like to get away from us clocking the time so discreetly. So I imagine if we started even adding more interventions in maternity care around measuring decisions, incision to incision, all that happens, what happens is an OBGYN, what we start doing is then adding even more layers of monitoring the clock. So I would like for us to move away from that and more to our fellow colleagues who are in midwifery who don't see that their role is to manage the pregnancy and to manage the time and to look at the clock and say, you must go, but are really looking for ways to allow physiologic birth. I would love for that language and for that opportunity to be in this conversation. So that's all. Oh, Lord, please let's not start talking about adding more things to quality improvement and measuring time, because trust me, that is the mess and the rabbit hole that we do in healthcare and QI that gets us to where we are right now, that doesn't honor the wishes and the desires of birthing people.
And that gets to, I think, some of the stuff that Scotty's going to talk about, that Karen Scott is going to talk about specific to, one of the ways that we don't want to undercut the efficacy of doulas or the mechanistic reasons why doulas are able to help curate a space for safer and more satisfied birth is Scotty always talks about how we try to manage time, but doulas and midwives move with people.
Exactly.
And so I agree with you, Joy. I really appreciate that sort of insight and our capacity to build on, the different perspectives of time, right? Because I think it's something that also gets missed. We talk about time in a very different way than the ways that patients and communities experience it.
So Joya, how would you describe though the responsiveness or relationship that other birthing practitioners may have, and how would you describe its success?
Yeah, I mean, I could just talk specifically, I'm gonna try to speak in the I. So I was trained to manage pregnancy on a labor curve. So my relationship to the birthing person is also in relation to a labor curve. So I'm watching the clock, I'm looking at her labor curve. I think that our colleagues don't even look at that. They don't even care. The labor curve is really watching the person's body, watching how they are responding. It's a very different orientation of where the knowledge lies, how you should be supporting them. It's just a very fundamentally different, and I would honestly get written up as a physician if I acted too much like a midwife, right? So this idea that my job is not to pressure you on a clock, but to spend more time honoring your body's natural progression is actually penalized in our current healthcare system. And so we would have to reorient ourselves around what we perceive our role is in birthing, right? As OBGYNs, are we managing a clock? Or are we working with the patient? And that's a very different orientation around care.
So I want to be respectful of the fact that Marina will have to leave us. And I wanted to bring up one of the questions that came up earlier, which is something that Hoya raised, which is really about massive awareness, creating and raising massive awareness as a crucial first step. And I'd like to start off focusing on the Native American and Alaskan Native community first on this question, and then move to the African American, just for balancing this table. So Marina, I'm going to ask you first, and then Abigail or Dr. Echo Hawk. Would you like to comment? Because you have clinical responsibilities you're going to be jumping to.
Yes, and I love that Abigail's going to comment. Yes. And I also, Brown Girl for Black Lives here. So loving listening to Dr. Hoya and Dr. Monica. So that's fantastic. I really think that I feel like I don't want to say too much because I think Abigail really touched on the necessity of just knowing what is real. Like, we don't really know what is real in terms of the data, in terms of the numbers for Indigenous communities. And I think that starting there, but also thinking about data as a sovereign thing to individual tribal nation is really important too, because it's like we can kind of get ahead of ourselves and forget that we're talking about decolonizing birth. And so we don't want to recolonize it by, creating these other systems that are then working against what it is that we're trying to do. And I also just want to say, Dr. Hoya, that I love your comment about time, because time is is everything. Like time is everything for our families, and what is the most precious thing that we can offer. So I just want to say that too. And I'm going to turn it over to Abigail.
Thank you. It's always an honor and a privilege to be in the space with you and all of these incredible people. So I would like to say, like there was actually, ironically, a really great episode of Grey's Anatomy that came out a couple weeks ago that showed the true experience of what a birth looks like for Native peoples. And my team and I worked with them to help represent it because it's supposedly set in Seattle. But what we find for American Indians and Alaska Natives, and I say that specifically instead of Indigenous, because our treaty rights are tied to that language. In federal policy, if we do not see the words American Indians and Alaska Natives, that means that our treaty rights are not being fulfilled and we don't get the resources that we need. So that's why I specifically use that language. And so we have to be careful in that as we go about measuring and using the word Indigenous to ensure that we are not harming tribal nations who are pushing for their treaty rights. And that language has to be used because it is treaty language. So back to the invisibility of Native people is that we're very invisible in this society. We aren't seen as modern and thriving. We're seen as in the past or simply just as dead. So in this episode of Grey's Anatomy, you'll see a cradle board. You'll see a mom mentioning how she isn't used to receiving good care in a large hospital system. And then at the end, you see this grandfather telling that child who they are. And Marina we tell the birth stories of our children. My children every year, they know their birth stories. We ground them in who they are. Those cultural practices are protective factors and are the thriving measurements we currently are not capturing as data folks on how our communities are thriving, because I survived the births of my children. And there are many of us who have thrived in our birthing times, but we don't measure that. And that's a problem with these systems, is that we like to talk about people of color and Native people. You want to talk about how we die, but very rarely how we live. And we have to shift that paradigm and move that narrative. And it has to happen within the research fields, epidemiology, biostatistics, and my team and I are working to do that.
Thank you. You just raised the use of television as a way to communicate and storytelling as a way to raise awareness. And now I would love to hear from Hoya, perhaps, about because you raised that in one of your major points.
Yeah, I mean, I think it's important for us to be seen fully and be allowed our full range of humanity. So similar to Abigail, we got to work with some of the writers for the TV show New Amsterdam that recently came out, and we're using it now as a teaching tool. We've used it with our partners in the New York City Health Department, working with hospitals and Alzin and Amita there, and really thinking about what would respectful care look like. And when you watch and you see even the difference between how providers look at that show versus how when patients look at the show, we don't usually see that time thing happening, right? Like we're automatically calling the lawyer to come in and intervene because we think we already decided you're not going to be able to participate in the delivery of your child or the birthing of your baby. And so we're already moved to calling legal services that time, like we're already on a whole nother space. And so what does it look like to fully see us as fully human, to step back and watch us push people through time, to watch us make decisions for people that they don't have personal body autonomy, and we're making these choices? Like we don't get to see that other side. So I encourage you to see the narratives and to work with other shows or other places, or write as much as you can. Monica and I get to write quite a bit, but to write and to talk and to speak and to share just ways to think differently about blaming and shaming. One last thing before I have to hop is that so much of the work for a long time into improving maternal health was focused on OBGYNs like myself and improving quality improvement inside of hospitals. But the data, as Lori Zephyrin and others have shown on this call, and Dr. Barfield, is that that's not where the money resides, as we would say. That's not where the action is. People don't just die at the moment of birthing. So we've spent so much money on and so much time on QI protocols for hemorrhage and hypertension, and to work on in-hospital births when there's an entire full spectrum of needs that people have, including support. So that's why we frame this around reproductive justice. That's why we frame this around human rights, because in order to switch us away from managing a clock, we must fully see people as fully human in all of their lived experiences. And we must honor their traditions, honor who they are, and not see them as only a bodily part. My father's an ophthalmologist. You can do incision stuff around eye surgery, this is not the same thing as a human being being born. And so we have to really reimagine what that looks like in supporting birthing people.
Thank you very, very much. Another question that was raised is, what are some of the means to address colorism in care and education? Colorism.
This is Monica. I'm gonna take this one only because, if you don't know the incredible work of AC Slaughter, who is at the University of Minnesota with Dr. Rachel Hardiman, who I already shouted out. She is a new R01 that's really looking at colorism. And so for people who don't understand that, it is this notion that for different skin shades or skin tones, that there is a differential way that both individually mediated and structural racism is experienced. And the theory behind it is proximity to whiteness, or people who have lighter skin have different experiences than darker skinned individuals. And so, this notion that there are even nuances within the way that people not only experience structural racism, but also intermediated and institutional racism, I think is one that is ripe for a discussion. I know it makes a lot of people uncomfortable because they haven't dealt with their own internalized racism or colorism. But the truth of the matter is, in pregnancy-related care, Dr. A.C. Slaughter and many others have shown that there is this differential treatment even among and between groups that experience structural racism. So again, going back to, Black, brown folks are not a monolith. And truth of the matter is we need to be thinking again around the wholeness and uniqueness of all individuals that we serve. And that's Dr. Jamie A.C. Slaughter, and it's ACEY-Slaughter. And she's at University of Minnesota with Dr. Rachel Hardiman, School of Public Health.
I'd also suggest people look up Elias Monk, who does incredible work. He's out in Harvard. He's a sociologist, just absolutely incredible work. There was recently just published a great article called Colorism and Physical Health Evidence from a National Survey. And I really suggest, if you've never heard of colorism, you take a look at the folks that Monica just talked about, and Dr. Monk, who's somebody that I follow pretty faithfully on this topic, to really follow that science, because I think for so very long, people didn't believe us that it was actually happening. And so follow this science, cite it in your work, and see how you as an individual can change your own practices.
Thank you. Thank you so much for both those suggestions. And, all of this conversation is going to be posted in about a week and can be made available to a number of individuals that you are connected through your various networks. So thank you so much for that. If it's all right with everyone, I'll ask one more question, and then I definitely feel like people should have a bit of a break. And that is, we've been talking a little, and more will be happening this afternoon and tomorrow about systemic racism. And I would love to hear your comments about the accumulated impact of systemic racism over the life course, and how that ultimately impacts the maternal health outcomes that are the focus of today. We could be focusing on many other aspects of the life course, but because we also have a reproductive justice life course theme, woven into our conversation, would anyone like to comment on this issue of accumulated systematic racism? And Abigail, I don't know if you want to go first, because I know you have to leave us to go give another talk.
Well, there's not enough time in the world, I think, to address this properly. But it is something that is absolutely seen. And so when I gave the story of the young woman in the very beginning, that woman was actually me. That's how I started in this work. That was my experience. I've had another sibling who almost died in her birth as a direct result of mistreatment. And then also the ongoing of how those stories pass down. And so those stories that pass down and the experiences that people experience every day, whether they're called microaggressions, whether it's folks using or saying things that people like, oh, that's a microaggression. It's like, no, those build up. It's not micro, it's violent, and it's violent to our bodies. And as a result of that systematic racism, of the fact that my children can't walk through a mall without somebody following them, to the way that you're treated in your hospital care system, to the way that you may not, get a job because of the way your name is too ethnic sounding. And I say that in quotation marks. That systematic racism builds within a body that creates adrenaline rushes, cortisol, all kinds of things that don't allow us to rest. And I call it rest in that sense. But that systematic racism is absolutely inhibiting our ability for people who birth to carry their babies, to carry them full term, and for them to actually survive that. So unless we as a field begin to address the systematic racism, which means a holistic view of the social determinants of health, and not seeing ourselves outside of transportation policy, but rather we should be inside of transportation policy, as an example, we're not going to see the changes that we're hoping for. We have to move beyond just thinking about what happens in one office visit. What happens to that individual when they leave that office, before they got to that office, and what was happening to them 10 years previously.
Thank you. And just to close it off, Monica or Marina, do you have anything that you want to add? It's totally
I think I just want to add that, yes to everything Abigail said, but also, that birth is ceremony, and that there is a spiritual component to birth that for me and my community really matters. And I think that the impacts of systemic racism, because clearly we don't have enough time to talk about all of them, but I think one of the greatest impacts is the removal of ceremony from the life cycles, whether it's birth or death. And I think that as we think about how we heal our communities, I think it's about also how do we heal all those places where this system of healthcare has removed ceremony from what is one of the most beautiful things for many people, and not for everybody. And even for those that it's not one of the most beautiful things to have a reproductive, event come up, that there still is a way of community based healing that our system removed from our communities.
Yeah. So, Monica, going once, twice.
Well, I'm gonna make this real quick because I could talk about this forever. But the truth of the matter is, we are talking about pregnancy. We are talking about the propagation of the human species, and birth is not the only legitimate end to pregnancies. And so sometimes I think we miss this whole notion that we study the outcomes of pregnancy. But the truth of the matter is, if pregnancy is the condition that we're studying, then I think everything's already been said by Dr. Abigail and said by Marina is correct. Karen Scott's probably going to talk about this when we come back from lunch, but we talk about birth as being sacred, right? And so I think there's a whole reproductive justice reframing where we need to talk about pregnancy as a condition, or pregnant capable people, or having organs where pregnancy is possible. But we also need to stop talking about the outcomes of pregnancy as if they are somehow segmented, not only across health services provision, but in the lives of people, right? And so as we continue to think about surrogacy and infertility and abortion and all the other sort of potential outcomes, that we continue to bifurcate or separate them out, in my mind, is a whole other level of structural racism that we don't talk about, because we don't talk about pregnant capable people as being whole members of society who have a life course that may end in birth, may end in abortion, may end in surrogacy, and that all of those things are part of the lived human experience.
Thank you so much. I think everyone needs a break, a bio break, and let's come back at 2:00. Thanks a lot.